The Curbsiders podcast is for entertainment, education, and information purposes only, and the topics discussed should not be used solely to diagnose, treat, cure, or prevent any diseases or conditions. Furthermore, the views and statements expressed on this podcast are solely those of the host and should not be interpreted to reflect official policy or position of any entity, aside from possibly Kashlak Memorial Hospital and its affiliate outreach programs, if indeed there are any. In fact, there are none. Pretty much, we aren't responsible if you screw up. You should always do your own homework and let us know when we're wrong.
Welcome back to the Curbsiders. I'm Dr. Matthew Frank Watto, here with my very good friend, Dr. Paul Nelson Williams. Hi, Paul. How are you doing tonight?
I've been downgraded from great, but other than that, I'm doing okay. How are you?
You're still great. Great, very good. To me, same thing. I didn't mean to downgrade you.
Sure.
Tonight on the show, Paul, we're talking about disorders of the gut-brain axis, which I think we're pronouncing DIGBA. We'll see if it catches on. And, of course, what we mean by this, IBS, functional dyspepsia, and cyclic vomiting syndrome. Our guest is the great Dr. Xiao Jing, Iris Wang. She's back for a third time on the show. And in just a moment, I'll tell you a little bit more, give a little more of a teaser. But first, Paul, what is it that we do on the Curbsiders?
Sure. Just in case the audience doesn't know at this point, we are the internal medicine podcast. We use expert interviews to bring you clinical pearls and practice-changing knowledge. And Matt, why don't you... I was going to say finish that tease, but that feels like a real gross sentence. So why don't you finish telling the audience what we talked about and who we talked to?
Well, we go through 3 cases, and we talk all about these disorders of the gut-brain axis. Particularly, we talk about how to approach them in a very patient-centered way, which is what I most appreciated about this, because oftentimes these patients are stigmatized or, I guess, told they just have anxiety, and that's really not it. So Dr. Wang did a great job of really telling us how she counsels patients and giving us just a wide range of therapeutic options for functional dyspepsia, for for IBS, and for cyclic vomiting. And there we did talk about some of the diagnostics, which really, Paul, there's not as much diagnostics here. It's a pretty minimal diagnostic. Most of it can be done in primary care.
Right. And keeping with the theme, it's really talking and listening to the patient, because we talk a lot about letting the patient's symptom presentation sort of guide what your therapeutics look like. So it's not algorithmic. It's not cookbook medicine. You actually have to listen to what symptoms are most bothersome, and that will guide your treatment a lot of the time. So really fascinating and helpful stuff.
Our guest, Dr. Xiao Jing, Iris Wang, she is a clinical gastroenterologist with a passion for teaching. While she's a general gastroenterologist, her clinical and research interests are in functional GI disorders or disorders of the gut-brain axis. She's currently an assistant professor at the Mayo Clinic in Rochester, Minnesota during the week, and an amateur baker during the weekends. Paul, do you have a pun?
I do not.
Okay. All right. So before we get to the interview, a reminder that this and most episodes are available for free CME for all healthcare professionals through VCU Health at curbsiders.vcuhealth.org. And so now, without further ado, let's get to it. Iris, so good to have you back. The audience probably knows you by now. I feel like maybe we just need to officially bring you into the team, but remind them, in case they haven't heard you before or they forget, remind them and tell them one hobby or interest outside of medicine.
You got to be careful where you invite me to be part of the team. I will totally take you up on that offer. My name is Xiao Jing, Iris Wang. I am a assistant professor in the Division of Gastroenterology at Mayo Clinic in Rochester, Minnesota. My clinical duties are a general gastroenterologist, but my clinical niche and research interests are in disorders of the gut-brain axis, and I'm so excited to be talking to you guys about that today. Hobby-wise, I am still an amateur baker, but I am producing many more carbs every weekend as we speak.
Good for you. Good for you. Stressful times,
Carbs make the world go around.
Iris, you had shared an anecdote with us before we started recording about karaoke. So I'm going to change up my usual question and actually ask me what your go-to karaoke song is, and if you don't have one, now's the time to make one up. So I'm going to ask you to commit to your go-to karaoke song.
Do you really think that I would have invited you to karaoke without a song for every specific occasion, depending on who I'm karaokeing with?
You get one.
Flo Rida, Club Can't Handle Me.
Wow.
That's a solid choice. All right. I mean, that was what I was going to guess, actually.
Thank you.
Paul, dare I ask what is your karaoke go-to song?
I mean, Bon Jovi's Dead or Alive. I feel like I don't know why you wouldn't.
Solid choice.
Yeah, thank you.
It used to be Total Eclipse of the Heart, but I think now that's kind of played out. But
It's also
for
really
me,
long.
but so fun.
True.
Well, Elena couldn't be here tonight. Our great super producer, Dr. Elena Gibson, who really put this thing together, couldn't be here because of clinical duties. And she did want to send in a pick of the week. So she said, this week I will recommend the documentary Searching for Sugar Man, a story of the life and work of the 1970s artist Rodriguez, which is also and she also recommends listening to the Rodriguez albums. So I can only imagine. I've never heard of this, Paul. It's probably something hip because it's Elena, and I will check it out and be a cooler person for it.
I think you would like it. It's actually a really great documentary. It's a movie I have seen, so it can't be that hip, but I liked it a lot.
I would put you and Elena in the category. Most of your picks of the week I've never heard of it, so you're making me more cultured by hearing them. Well, Iris, we have a lot to get to tonight, so I think we're just going to jump right into a case from Kashlak Memorial, and of course, the great Dr. Paul Williams will take us there.
Yeah, of course. So let's talk about Ms. Floyd first. So Ms. Floyd is a 32-year-old. She has no significant past medical history. She's coming to you with ongoing episodes of epigastric pain and nausea for the past year. Her symptoms are frequently worsened by eating, but exacerbating foods are not consistent. She describes one normal bowel movement most days and has no dysphagia, no weight loss, no heartburn symptoms. She has tried calcium carbonate and bismuth at home intermittently and without improvement. The workup so far by her excellent primary care doctor has included a negative stool H. pylori antigen, a normal CBC, a normal CMP, and Ms. Floyd is beginning to become frustrated regarding the lack of an explanation for her symptoms thus far. So astute listeners will know the title of the episode and know that we're sort of hitting into discussion of... Maybe this is my first question. What are we calling what we're talking about tonight? I've heard there's sort of functional disorders. Now there's disorders of the gut-brain axis, which we're going with Dyspepsia. Is that how the gastroenterologist abbreviated?
Yeah. What's the cool way to pronounce it as well?
I think it's still a tongue twister that I often get incorrect. But the official name for these disorders is disorders of the gut-brain axis, which I may have called interaction before, but there is an interaction there. But the official name is disorders of the gut-brain axis. Also, before we get too far ahead of ourselves, I have thought about my pick of the week for 2 months, so you have to let me give it.
Oh, I'm so sorry. How rude of me. All right, let's hear it.
I mean, you know this is the most important part of this for me. So I have to recommend this video game called It Takes Two. It came out on PS5, and it's very on theme with what we're talking about because it is a 2-player cooperative game and talks about kind of therapy. And it's about this couple that's about to get divorced, and then they're forced into this situation where they play through a cooperative game in order to figure out where they went wrong. The graphics are amazing. The play is actually very balanced between the 2 players, and if you have any sort of marital issues, even minor ones, this is the place to go to solve them. So high recommend. Also awesome mini games throughout. Right, I had to get that out.
I've never heard of that. Paul, you're the gamer on the show. Have you heard of this?
I have. I unfortunately don't have friends with which I could play it, but I've heard good things.
I'll come
Matt,
over, Paul.
step up.
We'll work on a relationship together. It'll be perfect.
Yeah, the show has created a major rift between me and Paul. We really need this game. So thank you.
Let's be honest. We wouldn't talk without the show, so it's probably helping us.
Okay, back to business. I'm sorry.
Yeah.
So disorders of the gut-brain axis. So these were formerly known as functional GI disorders, but then the title functional has become very burdened with bias. And so there's this move to rebrand these disorders because we now know a little bit more about why they happen the way they happen. And it does have to do with the interaction between the nervous system in the gut and the nervous system in the brain. But the formal definition are that these are disorders that are characterized by symptom clusters with limited findings of structural abnormalities on diagnostic testing. And that symptom cluster is going to be really important as we keep talking. Pathophysiology, we think, is a combination of altered motility, visceral hypersensitivity, a change in the epithelial barrier of the gut, mucosal immune dysfunction, microbiome disturbance, and gut central nervous system neural processing. That's a lot of stuff, but it's really important to remember that these all kind of interplay to produce the symptoms in these patients. That was a lot. So that's really not how I tell my patients about them, right? So when I talk to my patients about one of these disorders, I tell them, look, there's nothing that looks wrong on our testing, but that doesn't mean things are working correctly. And while we're getting better at testing for function or motility, testing for sensation, for hypersensitivity, for microbiome, all of that is far behind in terms of clinical relevance. And so just because the testing is normal, that just means we're not using or we don't have the right test right now to diagnose you. That doesn't mean nothing is wrong with you. And I do have to qualify that you want to say that, you are ruling out these structural things that will kill them, right? So you want to make sure you're allaying their fears, but validating the symptoms and the impact that these symptoms are having on their lives.
This just reminds me, we talked about long COVID recently, and it was the same kind of thing. We often the testing is negative. You don't find anything, but that doesn't mean there's nothing wrong. And like some of the other disorders on the show that we've talked about, any kind of chronic pain syndrome or fatigue, there's just like we don't have necessarily diagnostic tests. And a lot of the times you're just working with the patient and trying a lot of things. So I imagine that's going to have some of a model here, but by the time patients get to you, they've probably been pretty demoralized, I imagine, because you're pretty up there on the specialist chain. They might have even seen another GI before they get to you, right?
Yeah, absolutely. And actually, as a fellow, these patients caused a lot of anxiety, right? And in preparing for talking to everyone about these disorders, I've been thinking a lot and reflecting a lot about why these patients cause anxiety for providers. Because we can deny that all we want and say that there's bias, but it's true that we see a patient who has bloating, chronic pain, nausea, vomiting, diarrhea, and we kind of turn up our hackles. And I think, a couple of reasons that I've come up with, at least that pertain to me, is that these diseases aren't diseases that we are taught a lot throughout training. Part of it is because they don't kill patients, right? And that's one of the good things about them. But because they don't kill patients, they also don't show up on board exams. Because they don't tend to put patients in the hospital, as we go through residency training and we're mostly kind of inpatient based in our heavy kind of clinical learning and education, we don't learn about these patients. We see them as, these disorders don't fit an inpatient diagnosis, and so they don't have to be worried about right now while my COPD patient is crashing, right? So a lot of the times we don't, they're not necessarily an inpatient priority, and so we don't learn about that. And so perhaps we don't have the same kind of heuristics that we use for a lot of our other conditions. And what I mean by that is, when you see a patient with sepsis, heart rate increases, blood pressure decreases, you've been trained and taught to recognize that as sepsis, and you have an algorithm in your mind that you can automatically go down to say, okay, bolus fluids, check for an infection, let's get source control, let's start antibiotics while we do that, right? Those are kind of now mental shortcuts because as inpatient providers and residents and inpatient services, we do that a lot. Similarly, with outpatient disorders, like, we have the central criteria. And so when we have a sore throat patient come in, we can have a mental anchoring for that disorder. These patients don't fit in neat boxes. And so we don't often have those heuristics and those boxes and algorithms to go down. And that's sort of what I want to make sure everyone has tonight, is that we can have those. We can understand these disorders a little bit better. We do see patterns in these patients. And so when you do see those patterns, let me tell you, let us share with you what the algorithms are for you to go down so that it becomes a little less anxiety provoking.
This episode is brought to you by 10,000. And audience, I love 10,000. And in fact, I'm wearing a pair of 10,000 shorts right now because, like always, I'm going to get up in the morning and go for a run in my 10,000 shorts. I've talked about it before. They have a no bounce pocket for my cell phone so I don't injure myself when I'm going for a run, which I greatly appreciate. Plus, these things have odor protection. They're super lightweight. They're very well made. They test this stuff on like over 200 athletes who are real athletes, not like me, a fake athlete. And you know their stuff is high quality. I also like their versatile shirt, which is super lightweight and breathable. So when you're going on a run, it's not like that soggy cotton feeling. Right now, 10,000 is offering our listeners 10% off your purchase. You can go to 10,000.cc/curb to receive 10% off your purchase. That is 10,000.cc/curb. One more time, 10,000.cc/curb. And what we're going to do tonight, audience, the first case here, we're going to talk about functional dyspepsia. The second case, we're going to talk about more of the irritable bowel syndromes. And then finally, we're going to talk about a case of somebody who has recurrent episodes of vomiting. And hopefully we'll give you some tips, some diagnostics that you can do, and then how you can talk to patients and how you can think about approaching the treatment for that. So, Iris, this first case here, this person, it's a 32-year-old. They're having epigastric pain, nausea, negative H. pylori test. Like, where do we go from here? How do you think about the initial workup?
Yeah. Let's talk a little bit about functional dyspepsia, because we can put that label on, but actually it's helpful to further subdivide that label of functional dyspepsia into the two Rome-4 subclasses. And all of the criteria we're going to use today are based on Rome-4 criteria. And before we go into that, most of them, you have to fulfill the criteria for at least 3 months with symptom onset at least 6 months prior to diagnosis. That's sort of blanket across all Rome disorders. So for functional dyspepsia, you have to have one or more of either bothersome postprandial fullness, bothersome early satiation, bothersome epigastric pain, bothersome epigastric burning, and kind of no evidence of structural disease, including at upper endoscopy to explain the symptoms. That doesn't mean everybody needs an upper endoscopy, but we will get there in just a second. So we can break down functional dyspepsia into what's called postprandial distress syndrome or epigastric pain syndrome. And these are excellently named, right? One of them, you get postprandial distress. So you have to have the pain after you eat, usually severe enough to impact usual activities. And the other one, you have epigastric pain. The other thing about postprandial distress syndrome is bothersome early satiation. And I love asking this question to all of my trainees on rounds. So the difference between early satiety and early satiation is something that I don't think I learned until I was a fellow.
Paul knows, right, Paul?
No, I didn't know satiation was a word until about 5 minutes ago.
Yeah, I learned it in fellowship, right? So actually, a lot of what we consider satiety and call satiety is actually satiation. So early satiation means that a patient eats a smaller amount of food and feels full. And so when we talk about like heart failure symptoms of, are you eating a small size meal and getting full? That's actually early satiation. That is not early satiety. Early satiety means that you are actually full for longer. This is kind of important because we can correlate that sometimes, not 100%, but in my mind, right, expert opinion, not guideline based. Early satiation makes me think that the stomach is not able to stretch as wide as it used to, or that there's something preventing it or bothering it when it's doing what's called accommodation, which is increasing its size in order to accommodate that food bolus. I just defined a word using the same word, but you're with me. But we can test for that, right? And that's different from gastric emptying, where a delay in gastric emptying could cause early satiety, where you eat and then you're just full for a really long time because the food's just sitting there and not leaving. Why is this important? It's because functional dyspepsia and gastroparesis kind of overlap a little bit in terms of symptoms. And sometimes the only defining characteristic is this like normal gastric emptying study. But part of that is because gastric accommodation testing is not widely available. And when we actually do that testing, we can see abnormalities in one, in both, or a combination of that. So I like to kind of characterize the difference in those two terms, mostly because it helps us understand gastric function. So This then becomes...
I just want to make sure, can I try to summarize to make sure I got it? Satiety, they're full longer, and that's more of a gastroparesis feature because the food's just sitting there. It's not getting pushed through. The stomach's paralyzed. That's my simplified. And then satiation, they're full earlier in the eating process, but they don't necessarily stay full longer than usual, but they just get full really quickly.
Yep, absolutely.
And that's more of a functional dyspepsia symptom.
Symptom because we can't measure accommodation very well yet.
Mm-hmm. Okay.
Like we
There's
can...
not some sort of swallowable balloon test? This seems improbable to me. One of the things you guys like inflating in body parts, like this feels like it should be...
So that's how we used to do it. We used to have patients swallow a balloon, and then we would kind of fill up this balloon, and it was a barostat, and you could actually measure the volume of the balloon. Now, I can go on a very big tangent here, but I won't. But now we do it.
We don't have time.
Yeah, now we do it with a nuclear medicine test, and we can actually see the size of the stomach change. And I'm hopefully going to make some improvement in that, even with some clinical trials, fingers crossed, coming down the line. But back to postprandial distress syndrome. The other side of functional dyspepsia is epigastric pain syndrome, which is bothersome, either epigastric pain or burning that's severe enough to impact your usual activities that doesn't usually get induced by a meal. And these two overlap, right? But the reason why it's important to distinguish whether food is related or not is because we go down different treatment algorithms when we can make that distinction.
Yeah, and of course we'll have a figure that for the audience, by the time they're hearing this, we'll have a figure that lays these out. And there's some great algorithms that have been out there in the guidelines, and in the there was a Lancet paper I saw that had a nice figure as well. So we can link. We'll have sources for you for that. Well, so what would be the diagnostic workup? So H. pylori, I think, is part of it, right? So we've already done one of the steps. And what will we do next if that H. pylori test is negative? And do we have enough information here about Miss Floyd, our 32-year-old with epigastric pain, to say if they're more of the epigastric or the postprandial flavor? Which one would you think from this? We said the symptoms are frequently worsened by eating. Can't really pick any specific foods, the pains in the epigastrum, and those were the main symptoms. They've tried some bicarbonate or calcium carbonate and bismuth.
Yeah. I would, so everybody gets H. pylori testing, absolutely true. And the caveat there being how you do that H. pylori testing. As long as they're young and they have no alarm symptoms, we recommend non-invasive HP testing, right? So stool antigen is just fine. If they are any alarm features or they're over the age of 65, we do that H. pylori testing with an upper endoscopy. So that's sort of that difference. I think...
and that's because they're more likely to have malignancy or something serious if they're older,
correct,
right?
Correct, and more likely more important for us to assess for that. So this 32-year-old woman with no significant past medical history, I would label as postprandial distress syndrome because most of her symptoms are going to be worsened by eating, it looks like. It doesn't matter that the exacerbating food is not consistent. And this is an analogy I like to use for a lot of my patients. And I tell them that it's not the food that's the problem. It's the vessel, right? It's the stomach, it's the lining. And this is really important because a lot of these disorders of the gut-brain axis, patients attribute to food because often they're related to when they eat, and patients get so frustrated by not being able to identify which food is doing it. Even worse when they can identify specific foods and start eliminating them. And we run this risk of patients doing their own elimination diets and ending up on super restrictive diets with a fear of reintroduction and eating. We can get into that a little bit later if we want to, but suffice it to say that we have to reiterate that it's a function of how the stomach and intestines are working. It's not the food. That's the problem here. Mm-hmm. I think that another thought, in these functional dyspepsia patients too, is if there is a component of gastroparesis, of nausea, vomiting with these, right? It doesn't imply in our case, but a gastric emptying study can be considered. If they're not quite fitting in a oh, it's pain bloating after a small amount of food. But instead, they're also having vomiting. They're also having kind of regurgitation or bringing up undigested food. Something like that is when I would trigger a gastric emptying study.
Iris, so we've talked about with our patient here, we think maybe it's more of a postprandial flavor. We've done our H. pylori testing. They're younger than 60, so they don't need to proceed right to endoscopy. What would be next step? Are you going to do a therapeutic trial here, or would you do more diagnostics? What would be the next step, and how would you talk to the patient about that?
For this patient, I would go down a treatment algorithm for functional dyspepsia without any more testing. I would reassure her that I'm fairly confident that this is the disorder, that she has, that the H. pylori testing was really the only thing that's indicated from our large trials. And I would start with a PPI trial. Always a reasonable place to start. 4 weeks or so is generally what I give it in terms of time, and standard dose, so once daily PPI for most of them. H2 blockers can be considered as well. And actually, H2 blockers have been shown to decrease hypersensitivity in the bowels. And so for the upper GI tract, they are actually a pretty reasonable option as well. And they can have that extra benefit over a PPI when we're talking about things like functional heartburn, right? So
yeah.
Can I ask how you counsel to give those? So I know PPI or H2s are often used as sort of on-demand therapy. Is in terms of for patients with these symptoms, should they take them routinely, or what does that empiric treatment?
I would actually have them take it nightly if I'm trying to use it as empiric treatment for a hypersensitivity condition. Yep.
Great, thanks.
So short of the PPI, there are other kind of pharmacologic and non-pharmacologic treatment options that I use depending on the severity of symptoms and patient preference, in addition to any other comorbidities and medications that they're already on, right? And this is where that really taking a good history, I try to focus on what is the most bothersome problem for the patient in this situation, and I try to target my therapy to that issue. So starting with the non-pharmacologics, peppermint oil and caraway oil have both, this formulation called FD Guard has been shown in trials to be pretty good. But even the peppermint oil itself has had some good data for improvement of functional dyspepsia. And it does that by a mechanism of decreasing that hypersensitivity and as an antispasmodic. The caveat here is while you can get peppermint in many formulations, right? One thing the biggest thing I tell my patient is please don't drink essential oil, right? Because they could potentially find it and it's peppermint extract, right? But it's formulated for your diffuser. So that is poisonous and they should not do that. But the other, for older patients who may not want to take a medication, I actually have them try peppermint tea. And sometimes that peppermint tea might be enough if their symptoms are relatively mild. Now, peppermint by itself can actually cause relaxation of your GE junction. And so it will actually worsen reflux potentially, which is why all the formulated peppermint supplements on the market are enteric coated so that they don't release until they hit the stomach and are a little bit further along. So your kind of formulaic options are enteric coated peppermint, FD Guard, and also IB Guard, both of which are available over the counter.
And those are peppermint ones. The caraway oil, is there any specific name that might go by? People might see it as?
FD Guard and IB Guard are both formulated with both, and yeah.
Oh, they have peppermint
FD Guard
and
at least has
I
both.
See.
I think IB Guard has as well. Now, caraway oil, you can actually, and for the right patient, right, you can actually just have them take the seeds and brew it into a tea and drink it that way. And so that's an option too for patients who really want to try it, but don't necessarily want to pay for it or don't have access to it.
That sounds awful. You must be in dire straits if you're drinking steeped caraway seeds. That just sounds
well, so Paul, that's a really great point, right? Because these patients are in dire straits, right? This is the whole point, is that many of them are coming to us with, I've tried this and that and the other thing, and give me something. And this is where our empathy really comes into play, right? Because they are willing to try these things. This is really, usually really impacting their lives with no benefit from any of the other things they've tried.
Would you also tell someone with a postprandial distress or epigastric pain syndrome, any just blanket lifestyle things that you would tell these people to do? Because we've talked about some medical foods, I guess, and we've talked about PPIs and H2, but H2 blockers, what else might you do?
So there's more pharmacologic stuff, and then there's sort of dietary changes, right? So let me talk about the dietary changes since you asked. We think, right, if you're thinking about satiation as a mechanism, that it's that their stomachs aren't stretching potentially, or that the stretching itself is what's causing their symptoms. And so having them eat smaller meals so that they're not pushing their stomach to the limit that it has to go, and avoiding kind of things that would potentially slow down their stomach. So things that are really high in fat, for example, or high in fiber, may kind of irritate things in the stomach. Other things I would absolutely tell them to avoid would be NSAIDs, right? Every GI doctor will tell you to avoid NSAIDs, coffee, alcohol, smoking. The evidence for that is pretty weak. But you can't really go wrong telling someone to avoid smoking and alcohol.
Yeah, but coffee, Iris, you're really, watch out.
This is the wrong audience.
Weak evidence. So going kind of the other end of that spectrum, right? What other pharmacologic medications would I actually write a prescription for? This is where it matters whether they have postprandial distress syndrome or if they have epigastric pain syndrome. For the PDS folks, buspirone is actually the medication that is recommended. So what buspirone does is it's marketed as an anxiolytic, but it has a lovely kind of smooth muscle relaxation effect. And so it can actually help that stomach stretch. And this is sort of my disclaimer, right? Every time I write one of these medications for a patient, I will tell them, when you read the label for this, you will see that it is written for anti-anxiety. I am not treating you for anxiety. I am not telling you that this is related to your anxiety, because by the time they come to me, they have heard that somewhere before. And I'm very clear with them that I do not think this is in your head, that buspirone has clinical trial data for the treatment of functional dyspepsia. And if they look like they don't believe me, I pull out the paper for them. I have like all these papers on file. Because, some patients just don't, right? They think that I'm just trying to sell them an anxiolytic because I still don't believe their gastric symptoms. And so I will pull out a paper for functional.
You should put QR codes on the wall with all your common papers and just have them take a picture if you want to. I
have them in an EndNote library. That's about as hip as I can get.
Okay.
Because there's really nothing hipper than an EndNote library, for sure.
I plugged a PS5 game at the beginning of the show. How hip can I get?
That's true.
Yeah.
Fair.
So for buspirone, I have my patients generally start at 5 milligrams at night. I'll up-titrate them up to 15 milligrams TID before meals. So it's about 30 minutes before they eat. However, I want to make sure that they're not having kind of sedation effects from that medication because it is a little bit of an anxiolytic. For the ones who understand that anxiety does play a role, right? It doesn't cause these conditions, but it can certainly worsen a lot of that hypersensitivity. Those are the ones I tell, hey, this is going to be good for your anxiety as well. But in the patients who are not like kind of ready to make that connection, I separate it very clearly because that is why I'm using it. It's not because of the anxiety. For the epigastric pain syndrome, there we think that the kind of main pathologic abnormality, instead of maybe an accommodation or gastric function issue, is that visceral hypersensitivity, that they are too aware of what is happening in their stomach lining. And that's how I explain it to patients. It's that you didn't used to feel this, you don't have to feel this, but you are. And one of my colleagues online had actually given this really great analogy of your body was sending an alarm that there's a fire. And I can tell you now, from looking at your labs, looking at the testing, be it H. pylori or endoscopy, that there is no fire. Now we have to help your body turn off the alarm. And that's what the TCA is doing. It's turning off the alarm. And so TCAs have very good proven efficacy for pain control in all of the disorders of the gut-brain axis. And SSRIs, we use them, but the data is not as robust as it is for the TCAs.
Let me try and recap if there's no other agents for this. We started off with a PPI trial, 4 weeks or so. You can also give an H2, and that was a once daily PPI, or you could do an H2 blocker nightly. And then we could also recommend maybe try peppermint oil or tea, or caraway oil or tea. He really wants to try this caraway tea. Dietary changes were smaller meals, avoid high fat, high fiber because that slows stomach emptying. And of course, NSAIDs, smoking, they're bad for the stomach. If they have, if that's not working, we might think about buspirone as a muscle relaxant for people who have the postprandial distress. And for patients with epigastric pain, since it's more visceral hypersensitivity, we might use TCAs, which have better evidence than, you said, SSRIs.
Yeah. There are some new drugs that are being developed. One of them that I do want to mention is called vonoprazan. It's a potassium competitive acid blocker in trials in Japan.
We talked about that on the H. pylori because it's in the H. pylori.
Yep. And so hopefully that will give us a new option when, because some people don't metabolize the PPIs very well. Some other medications coming out in Japan called acotiamide, and it basically is altering your gastric function. But they don't know how it's working in humans. It just works. We've got some trials as well that are, again, fingers crossed, we're going to be able to start a clinical trial here too for some other competitive receptors. But basically, they're all targeting either gastric function or hypersensitivity.
Matt, as you're going through the pathway, I'm reminded of our Peabody Award-winning cough episode with Brad Hayward. This feels a lot like the same thing, where I think probably it's helpful to counsel patients up front. Listen, this might take some time for us to actually get you feeling better, addressing your issue. I believe that you're having symptoms. We'll go through things and we'll work through this together, but this might take some effort. I imagine there has to be some upfront counseling because it sounds like there's a little bit in terms of trial and error as to what approaches you're using and what's going to be effective for specific patients.
Absolutely.
Paul, if you'll remember the Thelma and Louise GIF that I put into a PowerPoint, Iris, have you ever seen this? It's Thelma and Louise. They're sitting in a convertible, and it just shows them clasp hands and drive off a cliff together. And I was like, yeah, this, treating chronic cough is kind of like a Thelma and Louise thing where you're just like to the patient, I'm in this with you till the end. Let's go. And it might be a wild ride because you might try so many different steps and treatments, and eventually there's invasive procedures. And this sounds like a similar thing. Do a lot of these patients end up getting EGD? With the chronic cough, bronchoscopy was one of the final pathways of it.
Like the terminal pathway.
I think a lot of them do end up getting EGD when they're not responding to some of these kind of lower therapies. Mm-hmm. But I would say that the way to sort of the society guideline and overall guidance on these disorders is to use that positive diagnosis, right? I have seen this before. I have, for better or for worse, I've seen other patients who are going through what you are going through. This is called functional dyspepsia. If you don't believe me, I will pull up the Rome 4 diagnostic criteria and go over it with you. And this is how we treat it. For certain patients, I will go through, we think this is what's going on. We think it's a hypersensitivity. And so this is why I'm using these medications. This is the rationale behind why I chose this for you. This is what you should look for. I think that a lot of this, it's the other reason for anxiety, right? Because it takes time. It takes you having to sit down and look a patient in the eye and make this treatment plan with them. And often we don't have that time. But I think it's important that you don't necessarily feel that anxiety or show it, because the more rushed you are, the more you drive up your patient's anxiety. The more they feel like you are on their team, the more willing they are to give these medications a try and not seek that second opinion and not force that upper endoscopy when it's not needed, right? So the other thing too is this idea of positive diagnosis, right? You want to introduce these disorders early. So when you have this pattern in a patient where you read this, the patient history, and you're suspecting a disorder of gut-brain axis, I tell them, I will send you for X, Y, and Z testing H. pylori, routine labs. If they're over 50, I'll send you for the upper endoscopy. However, if this comes back positive, you fit the category of these disorders, and I'm fairly certain this is what you will have. So that it's not oh, hey, the testing came back negative, so it's probably this, right? I bring it to them up front before I do the testing that this is a likely diagnosis for you, and there's nothing wrong with that diagnosis. But if this is the path and everything else comes back negative, I have a diagnosis for you, and I have a treatment plan that we will go down. Do not be disappointed if the EGD is negative. Yeah.
What strikes me about this is there's very little testing. It's H. pylori, some therapeutic trials, and they may have an endoscopy at some point, but it's not a huge amount of testing here.
Yeah, plus or minus like a gastric emptying in a patient who's very, very persistent or has that right profile where they could potentially have it. Yeah.
Right. Paul, do you want to tell us how do you think things ended for Miss Floyd? Do you want to wrap it up for us? What do we do for her postprandial distress?
Yeah, no, I'm happy to report. I mean, we stopped at the caraway tea, shockingly. Like, she had some tea that tasted like toast, and her symptoms relieved magically overnight. So we cracked the case wide open. She's doing great now. So strong work with Ms. Floyd. All right, we're going to move on to Ms. Cruz now. This is a much shorter case, I guess maybe because we have a presumptive diagnosis. But Ms. Cruz is a 40-year-old female. She's coming to us with a past medical history significant for gastroenteritis about 6 months ago, who is now presenting with recurrent loose bowel movements and abdominal pain. So right out the gate, sort of just given that very brief and abbreviated history, Iris, does that trigger any thoughts or any presumptive diagnoses that we should start chasing down?
Well, I mean, given the theme of the episode, I'm going to go with IBS, and I'm going to go with post-infectious
Right.
IBS. So let's talk a little bit about IBS. And I know you guys covered this on a prior episode fairly extensively, so we'll kind of go through that.
It was so long ago, it needs an update.
Rome 4 criteria for irritable bowel syndrome. It's recurrent abdominal pain, on average at least 1 day a week in the last 3 months, associated with 2 or more of either relation to defecation, so associated with a change in frequency of stool, or associated with a change in form or appearance of stool. And of course, with all Rome, right, criteria filled for the last 3 months, symptom onset at least 6 months prior to diagnosis. This is actually getting called into question a little bit in the irritable bowel syndrome diagnosis because this time lag makes it necessary that patients have to wait this long before they receive an IBS diagnosis. And often we already know it's IBS. And so it's a little bit of a minutia, if you will, right? But the societies are moving towards saying you don't need to wait 3 months necessarily to make an IBS diagnosis in the right patient. That way, drugs can be covered, patients can undergo less testing, and they can get treatment a little bit faster. So just something to be aware of.
We have done episodes recently with you talking about diarrhea, talking about constipation, and Elena made these great figures that walk us through a lot of what kind of workup you might do for someone with chronic constipation or chronic diarrhea. When you're thinking about this diagnosis here, what is like the minimal testing that someone needs to have done that you would recommend? And of course, we can post these figures that I'm referring to in the show notes.
Absolutely. And the societies have been really good about putting out guidelines for this testing, right? So that we can follow an algorithmic approach and that we can really minimize unnecessary testing. So again, positive test strategy. Mrs. Cruz, I'm going to send you for these tests because these are common conditions that may mimic what you have. However, what you have really sounds to me like it's post-infectious IBS. And if the testing comes back negative, which it's very possible it will, we'll go down that algorithm and we will still get you the treatment that you need. So Ibs Diarrhea Subtype, the testing that is recommended is to rule out celiac disease with serologies, so non-invasive testing, fecal calprotectin to rule out inflammatory bowel disease, and if that's not available, consider a CRP. But the fecal testing is actually pretty good to identify IBD versus IBS. And so if available, either a calprotectin or a fecal lactoferrin is what is recommended. The pathogen testing is not recommended, but in the cases of these like post-infectious or in patients with high risk, I will test them for either C. diff or Giardia or both. And for Giardia, the risk is kind of frequent hiking where they're drinking stream water. If their water source, if their primary water source is well water, I will test them for Giardia as well, or if they have kind of other risk for outbreak, like a family member had it or something like that. Other things to think about when sort of at the primary care level, I think that is really, really appropriate testing, and it's okay to stop there. At the GI level, if kind of a lot of our empiric stuff is not working, we'll think about doing a flexible sigmoidoscopy and taking random colon biopsies for microscopic colitis. It always sounds terrible when I call them random biopsies. I'm like aware of this term, but it just means that you're not targeting anything that looks abnormal, right? And that there's no kind of quadrants or anything like that. And then we do bile acid testing for bile acid malabsorption, and that's generally a 48-hour stool collection. High-risk patients for this include those who have abnormal kind of bile acid circulation. Anyone who's had ileal disease for any reason, right? Like if they had Crohn's disease and they had their ileum taken out, or like an extensive appendectomy, anyone who has had their gallbladder out and that diarrhea never got better, they're at risk for bile acid malabsorption. But a large percentage of our IBD patients have this as well. And it's important to know because they respond to different treatments, right?
You told us it was less than 100 centimeters of bowel.
Yep.
They like overproduce bile acids, so they might actually just be producing so much that they can't reabsorb them all.
Absolutely. And if they have lost their terminal ileum, then they can't recycle and recapture those bile acids as effectively. Mm-hmm. The other thing that always comes up is SIBO, right? The small intestinal bacterial overgrowth. And many people have many thoughts about it, and some people get like very into it. So I will not say too much about it, except that there are certain patients with certain risk factors where nobody will argue that they are at risk for bacterial overgrowth, okay? So these are patients who have any sort of reason for bacterial stasis, so some sort of diverticulum sitting in their small bowel, a Roux-en-Y gastric bypass, some sort of ileal blind loop, and then the patients who have dysmotility of the small bowel. But in those patients, you're not necessarily thinking IBS as your first diagnosis anymore. For IBS-C, testing becomes a lot more easier. We do, the like GI digital rectal exam, right? Or an anal rectal manometry or both. And then if they are above the age of 45 and have not had colorectal cancer screening, right? No new age, 45, that's when we do the colonoscopy, but that's for colorectal cancer screening. That's not for the constipation workup. So basically we're just trying to catch them, right? Like we'll screen you.
Yeah.
But important to note that that's why, right? Because insurance will cover one of those and potentially put the patient in responsible for a cost if you're doing this for a diagnostic purpose. So know that we're not doing it for diagnosis, it's for screening.
Yeah. So last time when we talked to you about constipation, we talked about we looked for secondary causes, medications and things like that, any red flags. And then we did a trial of laxatives. If that didn't work, they're getting the manometry and the advanced rectal exam and the manometry, the balloon expulsion. And if we don't find anything with the pelvic floor dysfunction testing, which is the manometry and such, then we might do these transit tests for slow transit constipation. And if there's no slow transit, then they're like, okay, this is probably IBS-C. But I imagine most patients don't even get that far or need to get that far.
The transit testing doesn't happen very often. And I think there was actually a listener question, right? I think somebody had posted this on Twitter. I think it was Katie Dunleavy. And the question was like, when do we do the slow transit constipation testing? Because the testing is so onerous and it doesn't necessarily change your management. I actually will treat my patients when they sound like IBS-C, right? When they have that pain component, I will treat them down the IBS-C algorithm. And when I think about transit testing is really when those laxatives aren't working as well as I think they should. And they're not getting a response and there's no pelvic floor dysfunction. And kind of somewhere the rest of their history is more consistent with some sort of neuromuscular disorder as opposed to a central sensitization flavor. And it's unfair for me to say, right, because I see these patients day in and day out. So I'm developing these kind of protocols and algorithms and like patient imprints. But if my patient has fibromyalgia, chronic fatigue, migraine, and these other central sensitization conditions that are known to be traveling with IBS, I'm not going to put them through slow transit constipation testing.
And how you mentioned sort of all this in terms of framing it as being as a positive diagnosis, and we expect the testing to come back relatively reassuring. So similar to the dyspepsia question, how are you explaining what's going on to patients? When you're talking to patients about, obviously they're worried about the worst, and I think always, cancer is a huge concern, especially I imagine with the constipation. But how are you framing the discussion about the background pathophysiology?
Depending on a little bit on kind of what is their predominant symptom, right? So let's talk about if the predominant problem is pain, is this visceral hypersensitivity that they are just feeling their colons move. And often that is what they're feeling in irritable bowel syndrome, because it's their colons like pushing that bowel movement along or trying to push the bowel movement along unsuccessfully. So I talk to them, depending on patient level, right? I will kind of pick and choose my spiel, but I'll tell them that the CNS, upper brain, and the enteric nervous system developed together embryologically. They used to be one nervous system, and then they separated. So this is really important because they still respond to the same exact neuromodulators. And so this is why we use them, right? It's not to treat anxiety. It's not to treat depression. It's to treat the gut nervous system itself because it responds to the same stuff. I tell them about how kind of that visceral hypersensitivity can develop from a number of reasons. One of them being kind of that post-infectious IBS is a really good example for how to start, is when they have an infection, a lot of things in their bodies become abnormal. So one is the microbiome. The good bacteria kind of get wiped out along with the bad bacteria, or there's this dysbiosis where the bad bacteria grow back and the good ones don't. That can cause an increase in sensitization of their bowels. So that basically they had this, fire. We'll go back to the fire example, when they were infected, but the infection has gone. The fire has been cleared. Now you just have to turn off the fire alarm. And the fire alarm is basically stuck on. So when I talk to patients about this, I try to gauge kind of where they are and I meet them there, right? So I'll just give you a couple of examples of the analogies that I'll use to explain this to a patient. So sometimes I'll start with how the nervous systems are related. So I'll tell them that the enteric nervous system and the central nervous system were one nervous system embryologically, and then as we developed, they kind of migrated apart. But that's why they respond to the same neurotransmitters, and that's why the neuromodulators that we use to treat anxiety and depression also work in the gut. And here's where I'll reiterate that I am using this to treat gut disorder and not to treat anything in the brain. The other thing that sometimes I'll use is that role of the parasympathetic nervous system, which I think we talked about in the constipation episode, where heightened kind of sympathetic nervous system activation can drive gut function to slow or stop. But really, when it comes to disorders of the gut-brain interaction, we're talking a lot of hypersensitivity, so that the gut is, again, feeling things that it's really not meant to be feeling. And how do we get that to calm down? So we talked about that fire alarm, right? The fire alarm was set off either by something like an infection or a cold or a course of antibiotics. Even though there was necessarily either the fire's already gone or there was no fire to begin with, and we just have to turn that alarm off. Sometimes I'll talk to them about, well, yes, we don't see a cancer, but you feel like there's something bothering you. Well, folks who have phantom limb syndrome, they don't have an arm, but they can still feel arm pain. That's how our central nervous system is wired. Sometimes I'll give them an example, especially in chronic constipation, where I know that they have stool kind of sitting in their bowels, irritating the lining. I'll tell them that, if I take my intact skin and I rub it over and over and over and over and over again, well, eventually it's going to turn red. And then if I keep doing that, it's going to get rubbed raw. And there was nothing wrong with it, but now the sensation has changed and it's hypersensitive. If there was an insult, like an infection, I'll tell them, well, it's like we cut your arm open and then didn't quite allow it to heal, and it's just still being irritated. When we kind of talk about more of a central sensitization, when the IBS comes along, and it frequently comes along with things like fibromyalgia and chronic fatigue, then I give them more of a talk about central sensitization. And what does that mean? Well, that means that the pain receptors that were carrying bowel function or kind of pain from the back or even from fatigue, Now, instead of kind of these thin pain fibers have been activated so many times that your body thinks that this pain signal is really, really important. So now it's become a myelinated superhighway. And we have evidence that this happens, right? That the MRI findings of chronic pain patients light up differently than patients who don't have chronic pain. And so I try to kind of take that science and what I know about the pathophysiologies of these conditions and make it relevant to a patient's experience, depending on how they're experiencing it. Does that help? Or is that like too scattered?
I don't think it's scattered.
That's great.
I think it's a hard condition to explain, and it's nice to have some sort of answer as far as the actual pathophysiology of this. Especially better than, as we've already said multiple times on this, don't just tell the patient, this is your anxiety. Here's an anxiety medicine, which is I think happens way too often.
Often it's not necessarily that, right? It's, oh, the testing came back negative. There's nothing wrong with you, but the algorithm says to try this medicine. And then patients see that it's an antidepressant and they get that wrong message because it wasn't conveyed, or explained why they were getting this medicine. And so they don't take it. So often it's well-meaning.
This episode is brought to you by Pattern. Shopping for disability insurance can be complicated and time-consuming, and busy doctors just shouldn't have to worry about whether or not they're getting the best rates and are seeing all the available discounts. Trying to research all the options and make the right decision while in training can make the process even more overwhelming, and that's why Pattern believes doctors have more important things to do than spend hours sorting through numerous insurance options. That's why thousands of doctors have trusted Pattern to compare and understand the disability insurance they are buying. And you do this in 3 simple steps. First, you're going to request your quotes online. Second, you're going to compare your options and ask questions. And third, you're going to secure your policy, and you can be confident that you have the right policy so that your income is protected. And with huge discounts for doctors in training and decreased requirements on labs and physicals, now is truly the best time to request your disability insurance quotes with Pattern at patternlife.com/curbsiders. Again, that's patternlife.com/curbsiders. And I think we should move on to talking a little bit about the treatment, and whether it's IBS-C, IBS-D, or mixed type. What's your spiel about treatment? And we can go through the pharmacologic and non-pharmacologic. And we do have some listener questions about some of the non-pharmacologic stuff as well. Maybe
I'll go over it, kind of the guideline-based stuff pretty quickly. And also you guys talked about this in a prior episode. So Fodmap Diet is a big question. Always a very limited trial with a nutritionist if possible, but only 6 weeks. And they have to start reintroducing. Otherwise, they're risking micronutrient deficiencies, but they're also risking persistent food intolerance. And that's something that I think we could talk about more, but doesn't get talked about enough. If there's significant cramping pain, I will reach for an antispasmodic, but the guidelines do not recommend for an antispasmodic for global IBS symptoms. There's just not enough data to support their use overall. Aggressive constipation management. The guidelines recommend lubiprostone, linaclotide, plecanatide, tegaserod, and we can give the doses and sort of what these are in the show notes, I'm sure. Peppermint supplementation has some good evidence for IBS as well. So that's that same medication we were just talking about for functional dyspepsia. Prescription laxatives are recommended for your constipation like we talked about, and rifaximin is recommended for IBS-D. However, I'm sure there are ID doctors who would skewer me if I'm recommending this, right? It is still an antibiotic, and I actually do try not to use it if possible. One, because it's so difficult to get covered for most patients. And I'm already talking to a patient about dysbiosis, right? I think that their microbiome was disrupted, and now I'm going to give them, unless I really truly think that they have SIBO and they need kind of that treatment to limit their flora, I try not to use that antibiotic, but it is recommended in the guidelines. So expert kind of deviation, if you will. Otherwise, for IBS-D, allosetron is a new kind of recommended medication. It's a serotonin antagonist for IBS-D in women. And then iluzatolline is still available, but know that you shouldn't use that medication if a patient doesn't have a gallbladder. So it is contraindicated in that situation. The TCAs, have pretty good efficacy for global IBS symptoms. But I will mention that because we talked about central sensitization coming as a package for a lot of these patients, they often come with the comorbidities of anxiety and depression. So they're already on something for either anxiety or depression. In those cases, I will always leave it to their treating psychiatrist or their primary care physician who's managing that other medication. I will not add on a TCA.
And Iris, since TCAs have come up now twice, can I just ask, do you have, in the absence of a reason to not prescribe one, do you prefer amitriptyline or nortriptyline, or what does that look like practically speaking for you?
I like to reach for nortriptyline. I also like dicypramine, mostly because amitriptyline can be a little bit constipating for patients. And so I don't want to send, especially if I'm trying to treat constipation, I'm not using a constipating medication. But nortriptyline and dicypramine seem to have better profiles for that.
And audience, I know we have some geriatricians listening, one of whom I have office hours with. So we, antispasmodics and the TCAs, be careful. If you got a 75-year-old, please, that's all I'll say. But Iris, do you have favorites out of these? Like you gave us a ton of options here: antispasmodics, aggressive constipation, peppermint. You said elocitron, maybe elozadol. Yeah, well, how do you say that one? Okay.
Don't make me say it again.
Elozadolene, and then the TCAs. What is, like, in primary care, what do you think we should be reaching for? Probably I'm not going to be able to get my hands on some of the newer, fancier ones. What do you think we'd have most success with and we should be comfortable reaching for?
Just kind of on the topic of geriatrics medicine, right? The other thing about these medications and TCAs and this whole central sensitization issue, it's not just overlapping kind of mood disorders, it's also chemical sensitivities. Often I hear from patients that they do not tolerate the TCAs or SSRIs because they end up with side effects. And so that's also another caveat that while they are good, they're often difficult to tolerate for patients. What are my favorites? I will use the secretagogues. I know we kind of talked about my constipation plan, so that is always where I start. I try to aggressively manage their constipation. In trials, that hasn't necessarily shown improvement in the pain component, but I think improving the bowel movement kind of is the key to reversing some of this hypersensitivity, right? If I think that that's where it started. So I will aggressively manage constipation if it's there. For diarrhea, and so from a primary care standpoint, it's very reasonable. And I've seen a lot of primary cares write for some of these secretagogues, either lubiprostone or even linaclotide seems to be a pretty popular choice. And unfortunately, often it's dictated by insurance. Yeah. It's like which one insurance will cover before I'm allowed to try the next one. And we could rage about this for a very long time. So I will use that. I think we had talked about probiotics a little bit too, and we could talk about it more because I think there was a question about it.
There was a question from Twitter, and I believe it was John Damianos, and he asked about probiotics, and then another listener on Instagram was asking about the microbiome and its relation to this. So I think these two questions, do you talk about that with your patients, and do we have anything there that you're recommending?
I talk about it a lot. So I talk about how the microbiome plays a role in both microscopic inflammation, which we know exists at the tissue level of IBS, right? That we have good data showing mast cell activation, increased neurons, et cetera, et cetera. So we know there's some sort of sensitization happening at the nerves. And we know that with certain microbiome compositions, that's more likely or less likely. So there's pro-inflammatory gut bacteria and then anti-inflammatory gut bacteria. And we know that it's better when the ratio is better for the anti-inflammatory folks. What we don't know is how to make that happen. And so that's sort of where I leave it with patients. I'll tell them that we have evidence that this matters, which is why I'm not going to give you a 5th course of antibiotics, because I want to preserve what you have, which is also why if you limit food for a really long time, the bacteria that help you digest certain products are going to kind of not be fed, right? Just to simplify that. And so you'll be less likely to tolerate that in the future, which helps patients kind of stop doing this. I will avoid all things that make me feel bad, right? Especially when everything makes them feel bad. getting a little off topic. So I help them to understand that the microbiome does play a really important role. And then I tell them, unfortunately, I have really no good way of fixing that right now. There's been some talk about stool transplant to fix it, but that is not recommended at this time. One, because it's relatively invasive. And two, there is a risk that you'll get some sort of infection from that stool, even though that risk is incredibly small. When you're using it to treat something like IBS, where the risk of mortality from the disease itself is low, you can't take that risk, right? So then we're left with probiotics. There's a couple of probiotics out there that do have some reasonable data, VSL number 3 being one of the few that have clinical trial tests. But the problem with a lot of these disorders and with probiotics is how heterogeneous everything is. And so your meta-analysis data is unable to be pooled because you're essentially using different drugs, but calling it all the same, right? You can't the probiotic formulations being used are so different that they don't pool very well. So you don't really know what's working and what's not. And then there's no FDA approval for most of these. And so you don't know what's actually in them. And so I'll tell patients, just like the prior speaker you had, I will say, if the probiotics are helping you, fine. All it's hurting is your pocketbook. If you want to give it a try even, fine. I would recommend, you can give VSL number 3 a try, or I'll tell them that there's specific strains that have some good data and to look for those if they're going to buy a supplement. I'll talk to them about natural forming probiotics. So like fermented foods, for example, yogurt with live active cultures has some data that it helps. And then things like kombucha, like kefir, data is very limited. But as long as it doesn't hurt, it's not unreasonable. And, sourdough is my favorite.
Paul, you can keep drinking your kombucha.
Oh, thank God.
Well, so with our patient here, let's go back to our patient. We've given a huge amount of options for IBS here. And Paul, that always makes me think that this is, as we said at the beginning, this is one of these just like another Thelma and Louise type thing where you're just going to try a lot of things. I do find that patients often, you just give them a lot of options, you empower them, and they will, if they're motivated and you work with them, see them frequently, they'll sort of figure things out that help get themselves better. I don't know that I can take credit for the IBS patients that seem to be doing well. I'm not sure if you have that experience, Paul, with your IBS patients.
I can go either way. I'd be much more interested in Iris's experience, but I feel like if you give too many options all at the same time, they're like, you're the doctor, you tell me what to do. So I think you'll have to sort of give some, at least some initial framework for them to select. And I think that's probably the most helpful way to empower them without overwhelming them, because there's a lot of choices here.
Mm-hmm.
Yeah. So let me throw a couple more in the mix. So we just talked about some of our patients have chemical sensitivities, right? And they don't want medications. Like they don't like taking medications. They'd rather go a natural path. Let's talk a little bit about CBT, because among all of the options, guideline recommended, CBT has excellent data, right? A number needed to treat of 4. So gut-directed psychotherapy. And this is very different than CBT or cognitive behavior therapy for something like anxiety, something like depression. These are specific psychotherapists who are trained especially in gastrointestinal psychotherapy. And so they'll apply symptom-specific management and treatment options. It's a short-term kind of 8 to 12-week treatment period. Number needed to treat is 4, similar in efficacy to a TCA with no side effect. However, right, the no side effect, the caveat is access, the caveat is patient time and provider availability, as well as insurance coverage. The other treatment, which is, of course, near and dear to my heart in this category, is gut-directed hypnotherapy.
Yes.
And that's got the same number needed to treat, NNT of 4, with very minimal side effects. So those options are, so with the hypnotherapy protocols, we do a 7-session protocol over the course of 12 weeks. And they take about 20 to 30 minutes each. I'll usually see a patient for about 40 minutes because we kind of talk about how they've been, we debrief after, and it's an option. Now, because availability is limited, right? Both of those options are now becoming increasingly digitized. And so there are more and more apps coming on the market to improve access to CBT and hypnotherapy for gut-specific disorders. And so that's going to be really exciting, I think, for patients and providers alike.
And for functional dyspepsia, the NNT that you were giving, was that for functional dyspepsia, cyclic vomiting, and IBS, or just IBS?
It's for IBS.
Okay.
That was kind of where that study was done.
Got it.
But what it's really targeting is the visceral sensitivity, right?
Yeah.
And so that's a common thread in all of these conditions.
Mm-hmm.
Functional dyspepsia specific hypnotherapy protocols are actually in development. And one of the hypnotherapy folks has developed a digitized version of that as well. And so hopefully we're going to be able to run that through a clinical trial soon and be able to provide that for folks to listen to on their own time, which would be really, really helpful, I think.
Very cool. I think we've ran through a lot of options here, and we definitely want to get on to cyclic vomiting because the audience was excited to hear about that, and I know Paul and I are too, because don't know much about that. I think one of the things I think we didn't mention yet, did I miss? Do you have a favorite anti-diarrheal for patients with IBS-D that you recommend? Is it loperamide or the combination medicine that I only know the brand name for, but like atropine, whatever. What do you like to use for that?
I do like to start with loperamide. It's just easy. It's usually easier for patients to get, right? I really don't like dealing with insurance companies, to be very honest with you. But the difference that I'll do with the loperamide is that I'll tell patients to schedule it. So often they'll tell me it didn't work, and that's because they're taking it according to the package instruction of take one after diarrhea starts and then thereafter. But I'll let them know that this is their pathophysiology, and it's the difference between trying to keep a horse in the barn and then trying to rein in a horse after it's already out of the barn. So scheduling the loperamide tends to be better than trying to chase the diarrhea after it's already out when it's a chronic issue.
She just said chasing diarrhea, Paul. It's late at night. I'm having trouble keeping a straight face. Iris,
why need to? There's no need to keep a straight face.
We're having fun. We're talking about poo. Iris, is bismuth also something that you find for these patients as maybe a second line, or just loperamide is generally sufficient?
I try really, really hard to diagnose them with something else, to be honest with you, right? Bile acid malabsorption, and then I'm giving them cholestyramine if they have microscopic colitis. Actually, I will use bismuth for that. That is actually for like one of the frontline treatments.
Sure.
Otherwise, I will try bismuth, but often I'm not finding a lot of success with it, and patients, they just really don't like it. I mean, it just doesn't taste great.
Okay.
And so I can't force them to keep trying it.
Well, lucky for our patient here, we'll wrap up this case. Miss Cruz, she was in the area. She was lucky enough to have you as her physician. She had some hypnotherapy, and just felt better after that. And symptoms are managed. Maybe she's using some peppermint now and again. And with this gastroenteritis, the people that have the post-infectious type, does that tend to go away as opposed to somebody who has more of an idiopathic cause of it?
I think they're more likely to resolve. And it's about 30% of them will respond completely. They'll resolve spontaneously. 30% will need some sort of therapy to help, and 30% persist.
Okay. So let's get on to the final case here, cyclic vomiting. Paul, did you want to take that one?
I mean, you already gave out the diagnosis, but I suppose I can at least read it to get us there. But so we'll talk about Mr. Banks. He's a 27-year-old, and I was told I guess you can't be 27 years old and a gentleman, so just male. With a past medical history significant for generalized anxiety disorder on citalopram, presenting to your clinic as a referral from the emergency department after presenting with recurrent nausea, vomiting episodes requiring IV medications to alleviate emesis over the past year. He does not drink alcohol. He rarely smokes cannabis. The symptoms of nausea, emesis, and abdominal pain last for about 5 days, and they recur every few months. Hot showers do seem to alleviate the symptoms, however. So already, Matt's steered us straight into the oncoming traffic of cyclic vomiting syndrome. There is this sort of hot shower. They once looked at a joint, and now so we have to assume that it's cannabis-associated hyperemesis. So could you talk us through the two diagnoses and sort of how they're related and how they're different? Because I feel like they're often talked about as if they're the same thing, and it sounds as if maybe they're not.
Absolutely, and I feel like at one point in time, I didn't even realize that cyclic vomiting syndrome was its separate condition. I thought everything was related to the cannabis, and it's really not. So, cyclic vomiting, it has a Rome 4 criteria, right? So at least 3 discrete episodes in the prior 2 years, 2 episodes in the past 6 months occurring at least 1 week apart. But the kicker here, right, is absence of vomiting between episodes, and other milder symptoms can be present. So they don't have to feel their best, but they're not vomiting between episodes. And this is very different than patients with like functional nausea and vomiting, where they feel sick almost all the time. These patients in between episodes feel fine, and they think that their disorder is gone, and then all of a sudden it hits again. The other big component of CVS, or cyclic vomiting syndrome, is this family or personal history of migraines. And it's really, and sometimes, they're actually kind of compared to abdominal migraines, because even though it's called cyclic vomiting syndrome, it can come with abdominal pain. The other important thing to note here is both cyclic vomiting syndrome and cannabis hyperemesis syndrome can have relief from hot showers. So you cannot diagnose cannabis hyperemesis just from the hot shower alleviating the symptom. Otherwise, the cannabis hyperemesis, really, like you have to have used cannabis for a prerequisite, right, for the suspicion. But what we're finding is it's actually quite prolonged use. So, usually it's not the occasional or rare cannabis user who's developing cannabis hyperemesis. It's the chronic users who smoke a significant amount kind of over time and on a regular basis who are developing this problem. But to keep things really, confusing for everyone, patients with cyclic vomiting syndrome tend to present relatively young, and they know that cannabis helps prevent the nausea. And so then they start using the cannabis because they were previously nauseous. And then it becomes this cycle of, you really have to dig back into that history to say, well, when did that nausea actually start? So that you're not just labeling them with cannabis hyperemesis when they were actually using the cannabis to try to treat this underlying disorder, but now the two have gotten all mixed up.
I thought they were totally separate things. I didn't really realize, but I have seen patients where you're not sure if it's the fact that they're smoking every day that came first, or the nausea and vomiting came first. And in some cases, a couple patients that I'm thinking of from the past few years, they couldn't even really tell me clearly which came first. And they at that point they felt that they had to smoke to try to help with their nausea.
Yeah. And sometimes I will tell them, I know you've heard this, that you have to quit the marijuana. Listen, I'm not blaming it on the marijuana, but I will tell you that it is not helping, that it helped in the beginning, but now you are almost dependent on it to treat the symptom, and we have to take it away. But that's kind of like asking someone to stop smoking, right? You can't just take it away. You have to help support them while you're trying to get them off their other, treatment option, basically.
How long? I always thought it was maybe a month off, but I was reading maybe even 6 months you have to take to tell them to stop. And for someone with a daily habit, that can be pretty tough.
There's no consensus guideline on how long you have to tell them to stop. And so I kind of, I will tell them that it can be months. And I think 6 months is not unreasonable. I have sometimes used, and this is kind of a weird, I wish Elena were here. I kind of have used sort of like relationship breakup guidelines, right? Like how long does it take you to get over a relationship? Well, it's like at least half the time you spent in the relationship. Well, I use the same kind of principle. If you've been smoking marijuana for a decade, this is not going away in 2 months. You have to be clear for a little bit longer. But that's sort of a wishy-washy kind of patient counseling thing.
I like it, though.
There's
That's
no
good.
guideline.
That's good. Okay.
Paul is not amused.
That's expert opinion if I've ever heard it, Paul.
No, that's terrific. And I'm just thinking, because I feel like, I don't know, it's when we were coming up in training a million years ago, when we were doing therapeutic leeches and tree finding and stuff, like that was just when they started talking about this cannabinoid-associated hyperemesis. And then as soon as everyone heard about it, they became so excited to diagnose people with it. But I just wonder how many patients were misdiagnosed with that just because you had, marijuana use is so prevalent. And so you hear just some sort of vague history of marijuana use, then they have sort of this recurrent episodes of vomiting. I just wonder how many patients unfortunately got saddled with a diagnosis just because it's appealing. And you also get to sort of maybe put a little bit of moralism on top of it too. Not that this has anything to do with what we're talking about, but just spitballing here.
No, but it can be definitely stigmatizing. And this also plays into how you counsel a patient and how you approach a patient with this. Because there's, they already know, they've heard this, right? They've heard that you're just going to blame the weed and not treat them. And so it's really important to make that alliance, to say, I am here to help you, whether or not marijuana was the reason, right? On the flip side, ED visits for nausea and vomiting in Colorado have doubled since marijuana was legalized.
Oh, interesting.
And so there is certainly something there. But how many patients are misdiagnosed? I don't know, because they are a very similar population. It's young patients who are probably also, in the time of their lives where they're experimenting with things because they weren't big nerds like me.
Iris, we had a listener from, I believe this is Instagram, Seema Jaga, who asked about, what are the most common etiologies for hyperemesis? They see this a lot in the inpatient side of things. We talked about the differential. Is it cyclic vomiting? Is it cannabis? But what else do you think about for these patients? What's the diagnostic workup or framework for this?
Oh, gosh. Vomiting is it's one of those diagnoses that give me heart palpitations, right? Because nausea as a symptom, we can talk about that probably for another hour. There's so many other things it can be, especially when it's bad enough to get someone admitted to a hospital. So for me, I always try to rule out not GI, right? Is there some sort of brain etiology that you have to worry about? Is the patient pregnant? Do we have some other, electrolyte abnormalities or disturbances? I think about I don't know if we have time to talk about all of this, but for me, the pathophysiology of nausea, right? We think about smooth muscle distension. So which piece of smooth muscle in your internal organs is being distended right now? Any of them will cause nausea. So that's why gallstones cause nausea. That's why when you have kidney stones, you get nausea. That's why gastroparesis gives you nausea. And so the differential is so broad that it is really hard to kind of give I don't have my heuristic algorithm necessarily, unless I see a patient.
That's probably why these patients end up getting CAT scans and
GI consults.
These patients, CAT scans and GI consults. And do these typically, I guess the first time someone presents with this, if it's intractable nausea and vomiting, most of these patients are going to get imaging, and oftentimes they might get an endoscopy. But what else do you think of? Does gastroparesis overlap with this? Is that something that people confuse for this? We talked about that overlapping with functional dyspepsia.
Yeah, it certainly can. And nausea and vomiting kind of in the setting of eating, I think it's always reasonable to do a gastric emptying study, but that's an outpatient workup. It's kind of generally relatively uncommon for that to suddenly appear as intractable nausea and vomiting, right? And so nausea and vomiting as a symptom, you kind of have to think about is this acute? Is it chronic? Is it kind of a change, or is this something insidious? Does it come with pain? Does it come with other symptoms? Is it morning? Is it postprandial? Is it, recurrent, or is it cyclic? And so there's a lot of history that goes into trying to work up the nausea.
Okay.
I'm trying to get myself invited back, apparently.
Okay, so we might have to do a nausea episode to follow up. Somebody mentioned, and are there action plans that are created for these patients? This was on Twitter. Pat Reeves was mentioning a CVS action. It's CVSA online, a cyclic vomiting syndrome action plan online, which is a nonprofit that exists. I had never heard of.
I actually looked at that action plan, and it's beautiful. I love it. I'm going to start using it. I usually kind of draw it out for my patients in chicken scratch. So this is beautiful. And so that kind of goes into a little bit about cyclic vomiting syndrome, right? And how it presents. And so we actually think about cyclic vomiting syndrome in phases. So there's 4 different phases of CVS. Phase 1 is kind of the inner episode time when the patients are feeling really, really well. Phase 2 is a prodrome where they usually can feel like that vomiting is about to start or that nausea is about to start. Phase 3 is the actual episode of kind of intractable nausea and vomiting. And phase 4 is the recovery period when they're settling out. And this might sound very familiar to a lot of folks because this is how migraines are thought about, right? And this goes into why cyclic vomiting syndrome is kind of sometimes tends to come with folks who have this history of migraine headaches, either in themselves or their family. And we actually treat it very similarly. So in the episode phase, or phase 1, our goal is to prevent an episode from happening. And we can actually use migraine prophylaxis to do this, including kind of amitriptyline, propranolol, and even cyproheptadine, which is a really good medication for nausea of all etiologies. In the prodromal phase, our kind of thought is to stop the episode before it happens, right? So things like lorazepam, this is when you're doing the sublingual Zofran, analgesics, and a triptan can sometimes help, especially if there's a headache component to that prodrome. So you're actually, doing very similar things to migraine prevention. During an episode, often patients with cyclic vomiting and CHS or cannabis hyperemesis as well don't respond very well to our routine antiemetics, but IV Zofran can help. IV ondansetron, right? Lorazepam has been used for these episodes as well as chlorpromazine, diphenhydramine, etc. And these are usually kind of being given not necessarily PO. So sublingual, IV, PR, kind of rectal, because patients are having trouble keeping the medication down. So if you're making them swallow a pill, it's not going to work as well. Sometimes patients take sedatives so that they're kind of asleep, right? Just like in migraine headaches, until the episode passes and then they recover. Sometimes if it's bad enough that they're hospitalized, we're using IV proton pump inhibitors, we're using IV fluids to try to get them through that acute episode. Some evidence for haloperidol as well as like a second line medication.
Right. Prochlorperazine and haloperidol, these antipsychotics seem to have some nausea benefit, the earlier generation ones anyway.
Yeah, absolutely.
Paul, are you raising your hand to ask a question or?
Just scratch my forehead.
Just scratching your forehead. Audience, Paul is scratching his forehead. Sorry for the interruption. Well, so there's a lot of options here. I think probably people are very comfortable with ondansetron, but I think sometimes people forget that these other things, like you mentioned antihistamines, and we talked antipsychotics, benzos, and and those can all have antiemetic properties. And then you mentioned, because there's some migraine overlap, the triptans can also be used, and probably intranasal or sub-Q, right? Because they might not be, if they're vomiting, they're just going to vomit up if you give them the tablets.
Well, you want to so the triptans are really good for aborting the episodes, and so you want to do it when they're kind of having their prodrome, and not when they're already vomiting. So then your options are a little bit more wide. So if you can prevent that episode from happening, which is why you have the action plan, right? So that if you're giving patients like these 4 different medication options, you want them very clear, like this is when you use this is when you use that. When you feel your prodrome coming on, you reach for this. There are other sort of heavy-duty antiemetics like apripitant that have been used in severe cases. So apripitant is a medication that has been approved for chemotherapy-induced nausea and vomiting. But sometimes it's like one of the only things that will work PO for these patients with severe vomiting. And so we apply for insurance exceptions, and we try to provide patients with a way to stay out of the emergency department.
This condition just really, I feel that the patients with this condition, they definitely get stigmatized when they're admitted recurrently. The hospital starts to know them, and sometimes when they have a heavy pain component and they're getting IV pain medications plus all these other IV medications for it, just I feel like these patients have a tough time. As far as like just counseling or non-pharmacologic, do you have any tricks, tips for the audience if they're working as a hospitalist and seeing a lot of these patients?
I think that if they have cyclic vomiting syndrome, right, there's no cannabis involved, often it's a little easier, right? Because there isn't that stigma associated. And then even though they're kind of the same patient population, people feel bad and then take care of them, and it's not such a problem. When they come in with a lot of pain, certainly, but I think that kind of making sure that they have a good outpatient provider who they have a therapeutic relationship with. And then if they come in with a good plan, right, I think it's easier for everybody involved to say, hey, this is what my outpatient provider and I came up with. I'm very it's like patients who have a pain contract, right? This is what works for me. I'm not trying to ask for more. But to make sure that the patients know kind of what's safe for them, and to develop that relationship with an outpatient provider so that they have a plan, whether it's inpatient or outpatient, and a person to call and notes to refer back to help kind of anchor their diagnosis. When cannabis is involved, I think it becomes a lot more complicated because there is a lot of bias. And so I think working with patients to help them understand that this is beyond sort of the marijuana use, right? That this is a condition that you are suffering, but like it or not, the cannabis is playing a role. And you're not telling them this while they're acutely vomiting. Like, they're not going to listen. And this is, it's just not helpful information, right? You treat them, you take care of the patient as they need to be taken care of. And then when they're in that recovery phase and ready to leave is when when I would sit down and have that conversation and say, this isn't good for you. You can't keep coming back like this. I know how hard it is, right? To ask you to just quit this and keep being without a crutch that you have been using. So let's figure out a way to kind of almost do the same as like addiction management, right? To try to get them off cannabis.
And these patients, they're feeling okay between episodes, but if they're having frequent episodes, what we talked about so far, they might be on a beta blocker like propranolol or TCAs to try to prevent, and then they may have something like lorazepam or a triptan in the prodrome phase to try to abort something before it gets out of hand. But then if they're admitted, they're going to be getting all these IV antiemetics and maybe pain medication as well. Anything else that you think is important for the audience to know about the treatment? I think we need to start to wrap up here. And this has been great. Covered a ton of ground, and this cyclic vomiting stuff is very new ground for me. So I really appreciate that.
I think there was a kind of question that had come up. So if patients aren't able to discontinue the cannabis, like, what do you do, right? You can't just keep telling them over and over without another option. So Haldol has been tried in the trials to treat the patients kind of through the cannabis use, and that has been helpful. And then we just treat them like cyclic vomiting. We give them the same plan. We try to kind of teach them about the phases and try to help them get through the episodes while cutting back. Because cutting back is still better than continuing, right? And eventually you may be able to get them to kind of cut back to a point where they can stop. But unfortunately, they have to be completely off for you to be able to tell whether this is going to resolve completely or whether there's going to be an underlying cyclic vomiting syndrome component, in which case we treat. Yeah. Trials for that also kind of in development, not by me, but other people.
We're going to be, and we'll be in just a couple weeks here recording a cannabis episode and talking about a little bit about cannabis use disorder. I'm not sure how much we'll be able to give solutions, because from my pre-reading, they've tried a lot of different things, but so far it's a lot of just like hypothesis generating stuff, not necessarily any slam dunk for treating it. Yeah. Other than like CBT and
hypnotherapy.
So hypnotherapy, we'll send them to you for hypnotherapy.
I can't do that.
Yeah. Well, with our patient here, Mr. Banks, we bring him into the hospital and get him through it with all this cocktail of medicines that you told us about, and then we develop a nice action plan and make sure we hand off to Dr. Paul Williams, who is a fantastic primary care doctor and very good at rapport building. So
sure, it's what I do. It's who I am.
Iris, if you had to give the audience some take-home points for what has been a whirlwind tour of disorders of the gut-brain axis. How are we pronouncing that, Paul?
A different way each time. I try not to, I think is the answer.
Digba?
It's better than the other one.
This is why. Thank you for illustrating my point.
Okay. Iris, take-home points whenever you're ready.
So I would start with, when you see one of these patients, take a deep breath, check your assumptions at the door. These are not psychosomatic or conversion disorders. Patients are suffering, and they need you to listen. And if you listen, those patterns will emerge, and it will be easier to identify one of these disorders in a positive light as opposed to ruling out. Be positive or be confident in your positive diagnosis. So these don't have to be a workup for exclusion, but even if you do undertake a workup, bring up this concept early so that it doesn't come up as an afterthought or as a nothing else is wrong, so it must be this diagnosis. Remember that the placebo effect is super high in these disorders, and that CBT works. But both of those things, the patient following through and this placebo effect, are predicated on their confidence in you as their ally and in your diagnosis that this is what they have. And so it's, explaining why you are sending a patient for this or why you are prescribing this for this disorder is so key and really helps it work. These are heterogeneous disorders, so the treatment is not going to be a one-size-fits-all. But certain symptoms will really respond to certain treatments better. And so your good history is a key. And the last thing that we really kind of didn't quite mention, but we've touched upon, is that these are multidisciplinary managements, right? You want to get your dietitian involved, a psychologist involved, and really have a team approach for managing these patients. And, use the Rome 4 if you need the actual diagnostic criteria.
Anything that you wanted to plug before we fade into the outro? Any resources, courses for becoming a hypnotherapist, anything like that?
Yeah, so a couple of things. So Rome has a psychogastroenterology section with an excellent website that has a find a provider option by zip code. So that's where I send a lot of my patients to find a psychologist to help them with CBT. Digital therapeutics are really going to be a game changer. Watch for them coming onto the market. They're actually getting FDA approval now. As therapeutic options. And then the last website that I'll mention is asch.net, so asch.net. And this is the accrediting society for hypnotherapy training. They will only train licensed providers. So you cannot be like average, random person off the street who wants to do show hypnosis. They will not train you. But also on that website is a kind of find a provider option so that you can help send your patients to those appropriate resources. And, you can cut this last part if you want, but my children's book needs a publisher.
We will not cut that.
Nope,
that
this is the place for self-promotion. Yeah, we're expecting a percentage.
All right, I'm going to stop the recording.
This has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
Yummy?
Oh, just like old times. Get your show notes at thecurbsiders.com, and while you're there, sign up for our mailing list to get our weekly show notes in your inbox. Plus, twice each month, you'll get our new Curbsiders Digest, recapping the latest practice-changing articles, guidelines, and news in internal medicine.
And we're committed to high-value, practice-changing knowledge, and to do that, we need your feedback, so please subscribe, rate, and review the show on Apple Podcasts, or contact us at thecurbsiders@gmail.com. A reminder that this and most episodes are available through VCU Health at curbsiders.vcuhealth.org. And a special thanks to our writer and producer for this episode, who we sorely missed tonight, Dr. Elena Gibson, and to our whole team, Beth Garbatelli, still our executive producer, Paul, for a little while before we have to let her go off to residency. Elizabeth Proto runs our social media. Tima Karganov does the website, and this episode was edited and produced with help from the team at Podpaste. And finally, Paul, Stuart Brigham composed our theme music. So with all that, until next time, I've been Dr. Matthew Frank Watto.
And as always, I remain Dr. Paul Nelson Williams. Thank you and goodbye.